Today is another session with a guest, with Professor Gabriel Christine from the Department of Radiology and Nuclear Medicine. And to introduce this important topic and also the speaker, our guest speaker as well, who'd be better placed to do that than my colleague Barbara Prinzek.
Fear not, we're not going to talk about algorithms prior to computers for the whole time. Otherwise, it would be a historical lecture. We will start though with algorithms prior to computers, and we'll use algorithms in medicine as an example. And I'll give a very brief overview. I'll also touch upon discussions about governing algorithms in medicine nowadays, more from the policy and ethics side. And I will then ask Gabriel to talk about algorithms in radiology. So it is a great pleasure, and I'll start with that, to introduce my very good and admired colleague, Gabriel Christine, who's, as Lucas already said, the chair of the Department of Radiology and Nuclear Medicine at the Erasmus Medical Center in Rotterdam in the Netherlands. And he had lots of roles in advisory positions besides his research and his chairmanship at his own department. He was also the president of the European Society of Radiology and the president of the International Society for Strategic Studies in Radiology. So maybe Gabriel will have the opportunity to also say a few words about what those societies do. These are actually policy bodies to a large extent. And why did I think it would be a good idea to invite Professor Christine here? Because he has this ability to be very clear about his own practice, which, as you know, not all doctors can do. And he also he's also very good in taking a sort of bird's eye view and reflecting from a critical distance on what's going on, and also taking a historical perspective. So I'll start with again showing a slide of Gabriel's background. And then I want to start with something that is referred to the information explosion. So this is one thing that is closely related to algorithms in medicine, but it's not an algorithm as such, namely a decision table. And this quote is from a paper that really draws attention to the information explosion, as the author calls it, in clinical medicine, where the author argues, and we need decision tables really to clearly communicate decision-making processes, because these have become so complex. So the decision tables have some properties that are highly useful. So the argument goes, they compactly represent all the elements of the process of decision-making, namely conditions, variables, and actions, conclusions, and the logic linking those conditions to actions. I'll give you an example of what that is in a moment. But what phenomenon do you think this person referred to? So when was this paper published? Can you maybe think of what the reason was that this paper was published? What year is it from? This was a bit of a sort of trap question. It is indeed from 1975. It was published in the Journal of the American Medical Association, which is one of the best, highly ranked journals in medicine. And it was published by a person who was drawing attention to clinicians having to digest, to process more and more information, so much so, well, he called it an explosion, that clinicians needed tools to help them sort through large amounts of data. Claudia Plant was talking about this last week as well in her lecture, but of course she was talking about very, very different volumes of data than the data sets that Holland was talking about in 1975. But I think it shows us that this problem of many practitioners, but here also clinicians, of having to sort through large amounts of data is a problem that is almost as old as human practice, one could say, and definitely clinical medicine. So this is an explanation of what these decision tables are. And the decision tables are a sort of step towards algorithm. So you see here you see on the lines on the upper side of the table, you see the conditions, and then you see how the conditions translate into actions in the lower part of the table. So you see, the certain properties of the bladder, yes or no, the age, infant or others, and then you see how the yes or no, whether a characteristic is there, whether a condition is met, translates into some kind of action. And that is, of course, the basis of an algorithm. So who can give us a very short generic definition of an algorithm? Lucas gave that already in the first session, and also Claudia gave definitions of algorithm, but in a very, very generic sense, how would you describe an algorithm? Not necessarily in medicine, anywhere. Jakob, please.
Hi. So as far as I understood, it's in a problem-solving mechanism. So there's an input, and there's a throughput, and there's an output. And basically, well, yeah, the algorithm deals with the input and gives you an output.
Very good. Yes, that's a very good generic definition. So an algorithm in its most general form is almost a recipe, a way to solve, as Jakob was saying, a problem. But I mean, that's not very interesting if you just have a recipe to solve one problem, right? So for example, if you ask me, how do I get from here to the opera house? I can tell you, you cross the ring, then you go, and so on. That's not so interesting because it doesn't save us a lot of time. Algorithms become really useful when they solve classes of problems. So, and that's exactly what Claudia was also demonstrating. Algorithms are powerful and also commercially valuable if they can help to solve classes of problems. And that's why they are useful in medicine and why they have been used for a long time. So again, this is just a table to show you that algorithms, this is actually the earliest publication in the Journal of the American Medical Association on the left, and the latest one on the right from the same journal that has the word algorithm in its title. So what difference do you see here? Apart from the obvious one that in one case you see a sort of graph, and on the other side you see an illustration of the United States of America. But what else do you notice? So the earlier papers in medicine on algorithms actually showed the algorithm. They sometimes also explained how people arrived at the algorithm. Don't forget that algorithms are ways to sort classes of problems, right? In clinical medicine. On the right-hand side, and it doesn't really matter what this particular algorithm was trying to do, but you don't see the algorithm anymore. You see the effects of the algorithm, the findings of the algorithm. So what problem does this raise for a lot of people that think about patient safety, ethics, governance? What problem does this raise? It's not necessarily a lack of transparency in that the authors of the paper on the right try to secretly hide, as some commercial corporations do, their algorithm, but it's just so complicated that they no longer publish the algorithm in a paper. You can probably get a hold on the algorithm if it's not commercial property or otherwise protected by intellectual property rights, but you can't even if we looked at it, we could no longer understand it. Whereas the algorithm on the left, you could very easily understand. So that that problem, the lack of transparency, raises issues for regulation and governance. So this is an illustration of what this algorithm actually did. Just trying to, sorry, I'm trying to make the slide visible to myself. It's called Computer-Aided Prognosis. They were developing a prognostic algorithm, so an algorithm that helps to make a prognosis. It's not a diagnostic algorithm that helps you diagnose a problem. This is what I understand Gabriel will talk about most, but it's a prognostic one. So I found it also very interesting because some of the language sounds very odd today. You know, you can almost hear the excitement of the authors when they said these collected data were extraordinary because of their wealth of clinical detail, and also because the details were now stored in a form suitable for electronic retrieval and processing. Only because the basic information had been made available in this form could we begin to contemplate its prognostic analysis with the aid of a digital computer. So that sounds maybe funny to our ears today, but of course, digitization and computerization was a game changer, which is a word we should not often use, but in this case, I think it's applicable. A game changer in the development of algorithms, because remember when I said that an algorithm is most useful when it solves classes of problems? That's exactly what computers enabled us to do. Not us, but us as a society. So this is how they did it in this paper. They looked at some of the properties that some patients had. This was a case of lung problems that people had. They looked at age, but they also looked at clinical parameters, even anemia, you know, if you don't have enough blood. And then they looked at what did people who had, I'm generalizing here, I'm simplifying here a little bit. People who had serious problems, which of the characteristics did they have in common? And those that had less serious problems and a better prognosis, or better actually outcome in this case, what did they have in common? And this is how they developed a prognostic algorithm on the basis of this information. So it was already data mining, although in a very, very pedestrian way compared to how it's done today. So now I'm coming to the end of my intro section. Yeah, so this is an explanation of what they actually did. This is from the original paper from the 1970s. That explains that the clinician, the human clinician, it's important that the human clinician is doing the prognosis, and what the algorithm, the computer algorithm should do is to help the clinician make the prognosis. So it was not intended to become a replacement of the human clinician, of the human doctor, but it was intended to become an aid, something that complements humans. And not so much has changed in some parts of medicine today, in the sense that, well, a lot has changed in how sophisticated and fast and complicated the algorithms are. But the idea that human beings will be totally replaced by algorithms, by artificial intelligence, I think has always been more the realm of science fiction than of actual development of software and algorithms in the clinic. So I already asked you what algorithms are. The best example of an algorithm, I think, is this. This is clearly not the clinical algorithm, but this is an algorithm that also illustrates how important human beings are as a corrective of a computer algorithm. So an algorithm, I think, is always a part automated machinery and a part human monitoring and correction. So what does this image show? Why is this an algorithm? No, this is not an airport control. I'll tell you what it is. It's the turnstile of the London Tube. Yes, Georgie. Yes, that's what it is. So people tap in and they tap out with the Oyster card, right? With the tickets, whatever they have, an annual ticket or just a pay-as-you-go ticket. And you also see that next to the man in orange is another person who's helping people who cannot tap in or tap out. So because their card might be faulty, because they may have run out of credit for whatever reason, but the whole system works, not because you have the turnstiles, but because you have a human being there that corrects for the false positives and the false negatives of the algorithm. Does that make sense? So the algorithm works for most people. This is why you have only 1 or 2 human beings and you have a lot of gates. But there's always false positives and false negatives that human beings with human intelligence correct. So there are 2 lessons here for us. Lesson number 1, algorithms that claim to not need humans anymore, not at all, never, be suspicious of them. Second, there are false positives and false negatives. If you have that at the London Tube, that can be really uncomfortable for the people who get stuck. But it's not a matter of life and death normally. In the clinic, it can be a matter of life and death. So false positives and false negatives in the clinic, when we talk about diagnostic algorithms, an algorithm that doesn't detect breast cancer, although somebody has it, it's a very, very different story. Okay, but lesson number 1, you need human beings normally. Second, lesson number 2, you will have mistakes that the algorithm makes because the algorithm solves classes of problems. So a reminder before I hand over to Gabriel, a reminder that algorithms and artificial intelligence as a catch-all phrase for anything that mimics human intelligence and makes the lives of humans easier. Algorithms are in healthcare in many, many ways. They are there when this was particularly important during the COVID pandemic, when doctors do telemedicine consultations, when they talk to their patients through Zoom, which is of course also using a lot of algorithms. It's there in medical records management, it's in data analytics, but it's also in all the communication that happens in the clinic. So there are lots and lots, well, clinical trials is very important. Drug development uses algorithms. So there are lots of places where we have been using algorithms in the clinic for a long time, where it's not so problematic because it's not so much a matter of life and death. If somebody, if there's an algorithm used in scheduling, appointment scheduling software, if somebody doesn't get the appointment that they should be getting, it's a problem, but it's not as bad as when there's a problem with a diagnostic algorithm. So, but just keep in mind that medicine has uses a lot of algorithm in many places where we don't normally talk so much about. What do we talk about? We talk about artificial intelligence, especially when it comes to the core clinical encounters, diagnostic algorithms, which Gabriel will talk about. There are lots of discussions at the moment about how to regulate algorithms. Lucas gave you a fantastic introduction into this, but also ontological questions. So questions about what those algorithms are, what artificial intelligence is, that we will not discuss today, such as what is an artificial intelligence using lots of algorithms? Is it a machine? Is it a new species? Should the algorithm be responsible and liable for mistakes that it makes? It's a question that is seriously discussed. Can we talk about autonomous driving with algorithm, when an algorithm drives a car, and so on? And for the lawyers among us, in healthcare, of course, there's a big discussion about when is software using algorithms a medical device, because then it's included in medical device regulation. So lots of discussions about especially artificial intelligence ethics at the moment. There are lots of corporations that are funding ethicists and ethics experts to discuss how to regulate artificial intelligence and algorithms in all fields of life, not only in medicine. Of course, this is an interesting topic in its own right, because you could ask the question of why Google, Apple, and other companies are suddenly so interested in ethics and what the agenda is. And I'm not going to go into this. And I will now hand over to Gabriel and stop sharing my slides.
Good afternoon, everybody. Hello. It's a pleasure to be here. I rarely give a lecture to non-radiologists or to non-physicians, but it is a great pleasure and a challenge at the same time for me. Let me pick up here at the end about predictions on artificial intelligence. Geoff Hinton, one of the fathers of artificial intelligence, stated in 2015 that probably in 5 years from then, so around this time, radiologists will become redundant because artificial intelligence will take over their jobs. Nothing can be less true than that. We have plenty of artificial intelligence algorithms there, just that we don't use them because we don't trust them. So let me start with that. So this is my hospital in Rotterdam. And yes, we use algorithms, and we always use the algorithms, even much earlier than Barbara stated. Can we have the next slide, Barbara? And just click through, because that was how medicine in the past was done. It was intuitive, but it was based on some signs and symptoms and on knowledge. And that knowledge was based on an algorithm. What did the lookalike of the patient mean? What did his temperature mean? Did the patient have pain? And they had to put together all these signs and symptoms in order to make a diagnosis and to know what the patient has. But this was intuitive medicine. It was treating not the causes of disease, because they didn't know where it comes from, but they treated signs and symptoms. Let's go to the next one. The medicine of the past years, of yesterday, was based on science and on relationships between the diagnosis, the treatment, and the outcome. And what we used were clinical trials in patient populations in order to find out what is the best way to treat a patient for a particular outcome. So diagnosis became a lot more important, and we have a lot of diagnostic tests. So those are tests, those that Barbara mentioned before, the false negatives, false positives, because not all tests are perfect, or let's say none of the tests are perfect. There are always possibilities for false positives and false negatives. But what we usually do, we do a number of tests, whether they are clinical ones or with sophisticated machines or from a blood test, and we put them together, and that's what we think it's evidence-based. That was what we did in the past. And already there, we needed some help, because the information that we gathered in order to get to that diagnosis and take a decision on what kind of treatment would work were so complex that we needed some aid. Next one. And definitely today, can you move, Barbara? Yes. We are turning towards what we call precision diagnosis and a personalization of care, because we are trying to choose based on certain characteristics, for instance, genomic characteristics, those people, those individuals in whom a certain drug, a certain treatment would help, because we know that drugs are not helping everybody. And this can be based on even more information on a lot of additional information that we cannot really handle on our own anymore. So that's where we need some help from outside, from computers maybe. Next, please. The next slide. So what is my profession? My profession is this, is summarized here in Chinese, probably you all understand. And it means, if you click once more, Barbara, that a picture is worth 1,000 words. We all know that, and we radiologists absolutely believe in that an image is worth much more than anything else. Next, please. So medical imaging was born, we know exactly, there is no other medical profession that knows so exactly when it was born in 1895. On the 8th of November, serendipitously, Wilhelm Conrad Röntgen found out that from a vacuum tube, something happened during night. A plate became dark, although in the room was dark. So the next day he went to his wife and made this famous image of his wife's hands, where those elements that were absorbing those unknown rays, the X-rays, appeared, so the bones. And that was for the first time that you could, from the outside, look into the inside of a person. And he received, obviously, the Nobel Prize a couple of years later. Next, please. So since then, medical imaging evolved tremendously. At the beginning, you can see in the 1900s, and actually the technology transfer already at that time was unbelievable. As I said, this discovery, this innovation happened on the 8th of November, 1895. I think in July 1896, the predecessor of my hospital here in Rotterdam, the Kool Single Hospital, had already an X-ray machine, a tube that was used. Very primitive, but they could make already at that time images. And then fluoroscopy came around, so that means that you could continuously use the X-rays to see even movements. And then after around the world, where ultrasound came from war technology, from the sonars that they used during World War II. That was put together into a picture, and that gave ultrasound images in the 60s, 70s, the CT, and then in the 1980s, MRI, and in the 1990s, PET, and further other technologies. So tremendous technological innovations that made medical imaging more and more important in medicine. Can we have the next slide, please? That shows you what we are capable to do today with ultrasound machines, reconstruct them in 3D or even in 4D. That means even with a video showing how it can move 3- and 4-dimensional images with multi-slice CTs, with MRIs, with ever higher field strengths, and then combined methods like PET-CT, where you combine a PET, a positron emission tomography, with a CT or an MR, and you can get both functional and also morphological information. So I was extremely fortunate to be a witness of this fantastic technological development that got into the daily routine clinical use and made the possibility to see into the inside of people without opening them, something that was previously not possible. Next, please. Because what we see is what we believe. And this is the quality of images that we can get today. This is a CT that is reconstructed in 3D with also administration of a contrast agent, and you can see very clearly the multiple vessels of the hand. So these are really images that even in an anatomy lesson, you cannot see better than with CT. So definitely medical images, and we are convinced of them, are worth more than 1,000 words. Next, please. So How do we get to a diagnosis? And let me give you an example here of an adrenal incidentaloma. So I will explain it to you what it is. And you can see the arrows showing to two tiny organs, and these are the adrenal glands. In German, we call them Nebenniere, and it's incorrect because it's not next to the kidney, but they are localized above the kidney. They are tiny organs, but very important because they are producing hormones that are regulating the blood pressure, for instance, hormones that are regulating many other things, like cortisol is coming from the adrenal glands. So very important, tiny organs. Unfortunately, these organs can grow, can become larger, and that's something that we may call adenoma, but they are also, because they are very well perfused, so a lot of blood comes to these organs, they are also a frequent site of metastatic deposition of malignant lesions. For instance, lung cancer, quite frequent cancer, makes very frequently metastasis in the adrenal glands. And because we use these sophisticated imaging methods, we very frequently find incidentally an adrenal mass, an adrenal enlargement. If you click once more, Barbara, or 2 times, then you will see 2 examples of these masses. I cannot show it with my arrow, but you can see the arrows there. On the upper slide, there is an enlargement with what we would call a lower attenuation. It's not very big. It's probably something like 2 or 3 centimeters in size. While on the lower image, and these are all CT images reconstructed in the coronal plane, this is a little bit more prominent enlargement of the adrenal gland on the left side with some inhomogeneities. We see there areas that are darker and areas that have a high signal, so are lighter. Now, what do we do with such a lesion, knowing that it can be an adenoma that is not so important? It can be an adenoma that produces an excess of hormones. That would be very important because it needs treatment, but it can be treated with a drug, or it could be also a malignancy, signaling that the patient has a malignant disease with already a metastasis that would worsen the prognosis for this patient. So what do we use? We use a diagnostic algorithm in order to come to the final decision. And we put into this algorithm not only the information that you see on the images, so the size of the lesion, the attenuation values, so the density of the lesion, the contours, are they sharp? But we put into it also some additional information like previous history of the patient. Does this patient has a known cancer, or other information like the age, the gender, and many more. Next slide, please. So this is the diagnostic process. The patient, not in the case of an incidentaloma. An incidentaloma is by definition found incidentally. We didn't expect it. We did the examination because of something else. And this is another big diagnostic problem, the so-called incidentally found alterations. I wouldn't even call them lesions because they are many times, most of the times, they don't have a definitely meaning for showing a disease, but you just find an alteration incidentally. But this is the diagnostic process. The patient has some complaints, engages with the healthcare system, and then what we do, what physicians do, is we look to the history, we make an interview, we ask how these complaints came, did the patient experience these complaints earlier, are there known other illnesses? We do a physical exam, less and less in these days, with a stethoscope, but also with our hands. We palpate the patient, we look at the patient, we look at the color of the patient, the color of the eyes. Some of these symptoms or signs are thousands of years old, and old physicians were even much better than we are today, because we usually go to a diagnostic test. we today say that a neurologist doesn't say hello to the patient anymore. He says CT, and he looks at the images before he even consults the patient. And then patient is referred to different types of diagnostic tests, blood tests, or other types of tests. And then, and this is what we do, this is the algorithm, and we try to integrate the information and to interpret that information. And then we communicate the diagnosis, if we have one, if we found the diagnosis, and based on that diagnosis, a treatment is decided, and then we'll have the outcome. So this is the diagnostic process. Next slide, please. So an algorithm is something that you see here simply on the left side, and Barbara showed a couple of those, and we use them daily. We don't look them up. On the right, you see the diagnostic algorithm for an adrenal incidentaloma that needs imaging, and then we decide based on the attenuation values, or Hounsfield units as we call them, so whether the lesion is dense or not, the size of the lesion, and so on. Based on these criteria, we decide along a certain algorithm what we think that this lesion could be. It is exactly like on the left side. There is a problem, the lamp doesn't function. Is it plugged in? Is the bulb burned out? So it is as simple as this one on the left side, just that our algorithms need a little bit more information, and there are many more possibilities usually there, among which we have to choose, and prior diseases or other clinical information may affect the decision that we take, the path that we go along this decision tree, as we call it, but we use on a daily basis algorithms. Next slide shows you three very typical algorithms for, let's say, patients who have pulmonary embolism or pain, chest pain, and are suspected of coronary artery disease. And I don't even see what is on the right side. I think it's an algorithm for interstitial lung disease. So yes, we do use them on a daily basis. And actually what experts are producing continuously are these types of recommendations. How should we handle a certain suspected disease or a confirmed disease? Along which kind of algorithms or decision trees should we go in order to finalize a diagnosis and make a decision about the most adequate treatment in that case? Next slide, please. So today we look a little bit differently, and that's where we are not able to do, even us radiologists, not taking even into consideration the other information that is available. But already in the images, there is a wealth of information. As mentioned before, we can characterize the lesions. Here, what you see is the lung of a patient with a lung mass. So it is a lung cancer, and you have below different examples, different sizes, different locations, different contours, different densities of those lesions, and you can quantify these characteristics. You can really express them in numbers. And if you can do that, then you can get the help of a machine, of a computer. If you click once more, then you can see that this is a so-called segmentation, and these are the descriptors of those lesions, the intensity, the shape, the texture. And if you put that all together and give it to a computer or to an algorithm, to a computerized algorithm, then that algorithm will decide whether this is a lesion that has a good or a bad prognosis, whether it needs treatment or doesn't need treatment. Next, and we call that, because we like the words of omics, so we call it radiomics. You can do it with any part of the body, with any question that you need. With a large number, you segment that information that you want to extract. You register it from different types of imaging. You extract as many features as possible, and then you put those features into a classifier. Now here you can understand that's something that we can't do in our brains anymore. The simple decision trees, it's something that we go along with. But if we need to classify 150 different characteristics of a certain lesion, then we need the computers. And these computers can learn from all these images and use what we call artificial intelligence. Still, we don't like it because we don't know exactly what the computer does. Somebody in the chat room said, it is a black box. Yes, it is for us an absolute black box. And that's why we still dislike it. When you click once more, it shows that you can use this radiomic approaches for prognosis, for predicting what would be the best therapy, for predicting whether there would be a therapy response, for diagnosing a certain disease. It doesn't have to be cancer, it can be anything else. Next, please. So what we do today is this data-driven medical imaging, because we gather as much data as possible from all types of imaging, from MRs, from CTs, from PETs. We try to quantify that, something that we would call deep phenotyping, and we add to that non-imaging data. So data from blood tests, data from genetic tests, data from clinical information. Next, please.
Gabriel, can I just briefly interrupt and ask whether everyone knows what phenotyping is?
So phenotyping, if I may.
Yeah, please do.
Phenotyping means how the individual, because we are looking to an individual, looks like, with all the characteristics that we have from the outside, but also from the inside. So phenotyping is characterizing, in fact. That's what we do. And genotyping is just one part of the phenotype. It is the genetic signature, but there is also other types of signatures. And the phenotype is the description of all those information. So imaging phenotype is the information that we get from imaging, but there are clinical phenotypes, there are other types of phenotypes. So we gather as much information and we try to put them together. So we put that into repositories of data. We usually compare it with a lot of reference data that is extracted from patients or from individuals that have not any complaints, that are so-called normal, because actually we need to know what is not normal in a patient, and then we can use this all this information extracted from this and compare it with a radiomics platform and with the genes, and apply deep learning and artificial intelligence. And this is actually the medicine of the future. Next, please. And it shows you that all this information can come from different sources, from wearable sensors. We maybe even don't need to reconstruct the images, maybe the raw data that we acquire from the patients with our sensors, with our imaging sensors, in fact, do not have to be reconstructed, but we extract all the information, put that all together, compare it with some repositories, and this is what we expect to be the medicine of tomorrow, data-driven medicine. So you click once more, Barbara, please, and then I am coming to the end. So this is what we think that it will be, AI and data-driven medicine, and you click one more. And this is from my favorite philosopher. It's clear that it will be different than it used to be. Thank you so much.